Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds. It is my pleasure this morning to introduce Ariela Orkaby. She is an assistant professor and cardiologist from Harvard University. She's currently an assistant professor of medicine at Harvard Medical School. She completed her training in internal medicine at the Boston Medical Center in geriatrics and preventative cardiology, and then went on to get a postgraduate degree in public health and epidemiology. She currently serves as the director of frailty research at the Division of Aging at Brigham and Women's Hospital and is associate director for research training in the New England Geriatric Research Education and Clinical Center at the Boston Veterans Administration Hospital. Dr. Orkaby is funded by the NIH and the VA system, and she studies the role of frailty in cardiovascular disease prevention. She is particularly interested in evidence-based medications in older adults who have often been excluded from our clinical trials. And her work has been published in many of the leading journals, including the New England Journal of Medicine and JAMA. And we are very privileged to have her talk to us today. So Dr. Orkaby, thank you for coming to Calgary. I'm sorry the weather is so wet. I promise you this is the coldest day in about 2 months. That's true. Thank you.
Well, good morning, and thank you for that kind introduction, and thank you so much for allowing me to speak with you today. So what I want to focus on today is the role of frailty in cardiovascular disease and thinking about how we might for frailty, whether it's in big data or in our clinics. So I have no conflicts of interest, just briefly mentioning some disclosures. I have grant funding, as mentioned, from the NIH and the VA, and I have done some consulting not relevant to today's talk. So the objectives for today are to recognize the value of frailty as a marker of risk, specifically in the context of cardiovascular disease management, and describe and learn together some of the tools that we can use to measure frailty across different settings and using variable data. But today, not starting in Boston, but taking us all the way to New Zealand first, which I haven't actually been there yet, but I'm going to see if I can get some conferences out there. Anyway, this is on the cardiac ICU floor in New Zealand. And 2 attendings and a fellow said, you know, we bet that we can tell if somebody is frail just by looking at them. And they said, let's test it. How good is our looks good from door test or looks frail from head to bed test compared to an actual measured assessment of frailty? And they use the Edmonton Frail Scale. Local, right here from Alberta. So any votes for folks who think that they did a good job? Were they good with their eyeball test? Any yeses? No's? All right, I'll show you the data. So the Cohen's kappa here are shown, and if you want to look for a good kappa, you want it to be above 0.5. That's about flipping a coin. They are all, with the exception of 1, way lower than 0.5. So your head of bed test or our eyeball test tends to be really bad. And that's because when you take an older adult, you put them to bed in the hospital with whatever condition they're coming in with, you put them in a Johnny or the hospital gown, almost everybody looks frail. And so we're really not very good at knowing who's frail or who's not, especially in the hospital. And this article and various others led to a series of editorials and calls to action from Dr. John Filala, who some of you may know up at McGill, who started the first geriatric cardiology program in Canada, to say we really have to upgrade our eyeball test. There are excellent tools that are out there, some of which are shown here that we'll go into in a little bit. And part of the driver for all of this was the TAVR procedure, because the whole TAVR procedure was really targeted at those who couldn't undergo surgery. Right. And so suddenly we're looking at people who are so vulnerable, they can't undergo surgery. We're going to do this other thing, which is less risky. But every surgery or every intervention in somebody who's frail is still, you know, a risk that we take. And so understanding who is frail and doing a better job of knowing that who that person is and where they are on that trajectory of frailty is the goal of today's talk. And to just bring it to Canadian data, since we're standing here in Calgary today, well, how many patients are we talking about? Are we talking about a few? We're talking about many. So as of 2020, about 1.6 million Canadians over 65 are living with frailty, and estimates are that's going to go up to about 2.5 million by 2030. And when we think about all of the needs that these patients have, well, that's tremendous, right? And in the context of cardiovascular disease, well, most of the patients that we see in our cardiology clinics are over 65, and many, many are frail. So even though we've done a really nice job globally, and these data are global, they go through 2010, it hasn't changed. You see that the lower lines here in younger adults, things have plateaued. And in fact, some of the data, at least before COVID, we're starting to see a reduction in cardiovascular events, except in older adults. So that's where we're seeing the greatest burden of cardiovascular disease. And again, in any of our clinics, we know that to be true. So whether we're looking at people with coronary disease, whether we're looking at heart failure, the burden can approach up to 80% in some of these patients. As a result, in the last 5 years, there has been an explosion of guidelines all across the world, whether we're looking in the US, whether we're looking in Canada or in Europe, that all now account for frailty. They all say, well, if you're assessing a patient with heart failure and you want to give them GDMT, well, you're thinking about a new SGLT2 inhibitor, think about frailty. You're thinking about a valvular intervention, measure frailty. You're thinking about a statin, well, where are they with their frailty? The problem is none of these tools actually tell you how to define it. So that's tricky. So anybody here in the audience want to tell me, what is frailty? Talking about it for the last couple of minutes, but what is it? Good. Excellent. Perfect. So to take that a little further into the definition that was published in the Lancet by Andy Clegg and colleagues about a decade ago, frailty is a state of vulnerability to poor resolution of homeostasis after a stressor event. So exactly right. And as a consequence of cumulative decline in many physiological systems during the lifetime. And the difference between a fit individual and a frail individual is how will they do when they have a hit to that system? So if they're coming in with an acute MI, they're coming in with a pneumonia, well, the person who's fit is more likely to to the hospital and get back to their baseline functional status. The person who is frail is much, much less likely to get home. And that's where we think about that burden, both on the patient, on their caregivers, and on society generally. So if we can identify those people who are frail, we might be able to mitigate the badness that comes afterwards. So let's frame our talk today, the time that we have together, through these two patients, both real patients that I saw in my geriatric consult clinic. The first is Mr. D. He's a 79-year-old retired engineer. He lives alone. He uses a cane for mobility, and his son has recently started to manage his bills. He has atrial fibrillation, coronary disease, HFrEF, hypertension, arthritis, BPH, and GERD, and recently underwent prostate surgery, and he had some confusion after that. His atrial fibrillation is a newer diagnosis, and the question is, should he be anticoagulated? And if so, with what? The second patient is Mrs. Y. She's an 86-year-old retired pharmacist. She lives in assisted living. She uses a walker. Her daughter helps her with her groceries. Otherwise, she really manages everything on her own. She has severe aortic stenosis, diabetes, hypertension, hyperlipidemia, osteoarthritis, chronic kidney disease, and some anxiety. And the question is, should she undergo TAVR or SAVR for her severe AS? She's having more trouble with dyspnea and exertion. So keep both of these patients in mind. So let's start with, how is frailty measured? So there are really two conceptual models that we use when we think about how to measure frailty. But the reality is that there are more than 60 tools, and a really nice review by Ariela Ijaz recently from Hopkins in Jack went through all of these different frailty measures, if anybody's interested to look at that. But the real two definitions that we use are based on two theories. And I use this actually in when I lecture at our School of Public Health in our frailty course as an example of two careers in research that went in completely different directions. So Linda Freed is a geriatrician. She was working down at Johns Hopkins down in Maryland in the 1990s. And she said, I've got the cardiovascular health study, this existing data that was collected in the 1970s. Let me see if I can identify variables that can highlight who is frail, who is vulnerable, and who is not. And she approached this as a very physical phenotype, sort of you know it when you see it, right? Maybe a hunched over older woman who is walking very slowly. And so the 5 very interconnected variables that she came up with are weight loss, low muscle strength, slow walking speed, low physical activity, and low energy. And if you've got 3 or more of these, you're considered frail. It's not so simple to measure these. If you are looking for muscle strength, you need to measure grip strength. You need to do a 4 or 5 meter gait speed test. You need to measure physical activity using a questionnaire, but it comes up with a nice score that's really very physical. Some of the criticisms are it doesn't account for cognition. It doesn't account for nutrition. It doesn't account for multiple medical conditions that will often drive frailty. Now, in parallel, so this was published in 2001 in the Journals of Gerontology. It's one of the leading definitions of frailty. In parallel, Dr. Ken Rockwood over at Dalhousie, also in the 1990s, was developing a prospective cohort study called the Canadian Study of Health and Aging. And he's also a geriatrician. And he said, I want to prospectively follow people and see, well, is there a threshold at which you accumulate enough different things to the health system and then you become vulnerable? And he thought of frailty more as these buckets of different domains that can influence the body. So that includes multimorbidity. It includes mental health. It includes cognition, nutrition, physical function, perhaps even social determinants of health and other things. And this can span all the way up to 90 or 100 different items. That's impossible to do in clinic. I'm just going to say it for what it is. It is impossible to do in clinic. And yet from a research tool, or if you're doing a comprehensive assessment, comprehensive geriatric assessment, it could be possible. And so these two different theories of frailty have really driven the literature over the last 20, 25 years. And it turns out that depending which of these two theories you use, you're going to identify different people as frail. So this is Framingham Heart Study data that I had an opportunity to work with. And when we ran a Rockwood type Frailty Index, that is that count of many different things, we found that about 22% of the Framingham cohort over the age of 60 was frail. When we used the Fried phenotype, only about 7% were frail. Well, that's just the nature of the two theories. Now, I didn't bring the data here, but they actually don't even overlap. They're not often the same people, which is fascinating when we think about population health management. Maybe we actually need to use more than one definition of frailty. At the same time, when you use both definitions of frailty, you often get the same result if you're looking for an outcome. So this is data from the Physician's Health Study, an old primary prevention aspirin trial for those who might be familiar with it. And we asked the question, is there a role for long-term anti-inflammatory medication use for frailty prevention? Shown here, this is not actually the point of the slide, but here we were looking at long-term aspirin use and whether or not it prevented frailty. The real point here is that these curves are nearly identical. Whether you're using a Rockwood type frailty index or a variation on a Fried, we found the same thing, that actually moderate aspirin use over about 11 years was associated with a lower risk of frailty. And so that's very interesting. Two totally different theories, identify different people, but same outcomes. So as we're thinking about using our healthcare systems, and we were just talking earlier about Epic coming across Alberta, and in the US, there are some healthcare systems that already are integrated across the nation, in the UK and other places. There has been a real push to say, can we identify those who are frail using existing data that we already have? And so I'm going to share what we've done at the Veterans Health Administration. This is the largest integrated healthcare network in the United States. It has served over 25 million veterans over the last 150 years, and currently has about 9 million active enrollees. And what's really incredible about the system is it's a single health record system, electronic health record system across the entire nation, over 170 medical centers with all of their associated clinics. And this data can all be linked out to Medicare and Medicaid, which are the national insurance for those 65 and older. And so it just lends itself to an incredibly rich data source. This is just the Boston VA. We're at 3 different sites. And so what we were hoping to do is see, could we use the data that's already being collected as part of routine clinical care to create an automated frailty index that we could use at least at the beginning for population health and hopefully for clinic in the future. So we captured data from 2002 to 2012 and identified 3 million veterans over 65 who were regular users of care. And we were able to construct a frailty index based on that same Rockwood approach, covering multiple different domains of frailty. It ended up with 31 items that actually encompasses many additional variables that go into it. And what we found was that the prevalence of frailty in 2002 amongst about 1.6 million veterans was about 30%, And by 2012, that number had increased by 50% up all the way up to about almost half of veterans over 65. And that number has really stayed stable into 2018 and beyond. So that's a very high burden of frailty for a healthcare system that is already caring for a very vulnerable population. Now we took it a step further and said, well, is this frailty index identifying people at risk of poor outcomes? The answer is yes. This is just looking at a 2-year risk using the 2012 to 2014 cohort. As frailty level goes up, there is an increased risk of death. And so here down on the x-axis, we're looking at the frailty index level. You see it kind of maxes out around 0.8. That's because you can't have everything wrong with you and still be alive. There is, a threshold at which it's no longer compatible with life. And about 0.2 is the suggested cutoff for where we start to see an increased risk of death and where we start to count or consider somebody as frail. What was really fascinating, and this gets back actually to the answer earlier, is that frailty is independent of age. And for everybody who trained in internal medicine, if you go back to your residency days and you think about all the prevention things that we learn about, colonoscopy screening, mammography, and everything, we have guidelines for people who are in their 60s, right? And everybody who's in their 60s should have a colonoscopy every 10 years, right? Well, if you're a frail 65-year-old, your average life expectancy might only be about 5 years or less. Well, maybe we should be reconsidering this routine screening that we're doing them for that individual. At the same time, if you are over the age of 80 or 85 and you're not frail, which are many of the older adults who are around, well, your average life expectancy, 6-7 years, maybe longer. And yet we have guidelines that just cut off randomly at the age of 80. Think of the pooled risk equation that we might use for ASCVD risk. It doesn't work after the age of 79. And yet there's nothing magical that happens at the age of 80 that's all that different from the age of 79. And so there's a growing understanding that chronologic age is just one piece of the picture. We really need to have the bigger picture, and frailty is one marker into that. So the UK is far ahead of every other country that's been thinking about frailty. This is work shown again from Dr. Andy Clegg. This is their frailty index and showing outcomes across primary care for individuals aged 65 to 95, very similar to our data. Their prevalence of frailty was also approaching about 50%. And when you look at the higher levels of frailty, there is an increased risk of dying over the next 5 to 10 years. This has been launched now into all of primary care. So it went very quickly from research into the clinic. And so all primary care patients who are seen across the NHS in the UK have a frailty index that's calculated from that existing data, which is really cool, right? We're doing all this work. We're generating all of these codes and data in Epic or whichever healthcare system, electronic record system we're using. And then we can pull that data on the other side and come up with a score and at least flag, this is somebody who you should be worried about. And there's a Fit for Frailty campaign that's all over the UK. I found this study really, really interesting. So this is a primary care clinic in Edmonton, 85 consecutive patients who were seen. And what they did was they ran the same UK electronic frailty index on their data, and then they compared it to an in-person comprehensive geriatric assessment, the things that we do in geriatrics clinic that can take 90 minutes or even longer. And it turned out that the correlation was excellent, right? If you've got the data in the system and you're already doing all that work to identify all of the things that are going on with your patient, it corresponds very closely to doing the comprehensive geriatric assessment. This is some of the best data in the world, and it's right here from Alberta. So kudos to Alberta. Well, so now we've thought a little bit about how we might use the electronic healthcare record. Well, what about frailty now, specifically in the context of cardiovascular disease? So using some of the large cohort data that are available. So this is the National Health and Aging Trend Survey in the US. This is a freed definition of frailty. About 3,300 participants who were over the age of 65. Well, the findings here really highlight that somebody who's frail is at an exceedingly high risk of having any cardiovascular disease over 6 years of follow-up. So these are all incident events. This is the freed. So these assessments were done in person. This is extremely labor intensive, obviously very important data, but could we use our electronic frailty index to identify the same people at risk? And the answer is yes. So this is data from the VA, again, using that electronic frailty index. And we were able to identify people who were across the spectrum of frailty, had increased risk of every cardiovascular event again. And this was actually independent of pre-existing cardiovascular disease. So risk of second events as well was much higher in those who were frail. What's interesting though, is when we look at a time series, the rates of individuals who are frail are coming down, but the highest risk of cardiovascular events still is remaining quite high in those people who are frail. So we're seeing a decline in both frailty and overall cardiovascular events, but it's still those who are the most frail who have the highest burden of cardiovascular disease. There's been some work now looking at, well, can we use frailty as a risk factor? And so this is data from a large cohort, also US data, about almost 300,000 individuals in a Medicare fee for service. So it's just one of the insurance claims that we have in the US. And frailty could improve the risk prediction of 30-day mortality after an acute MI or heart failure admission. And what was really interesting, this is the hospital frailty risk score that was also developed in the UK, very specific for hospitalized patients, very similar to the Rockwood. The point here is that it works really, really well on a population level to identify, well, who might need a little bit more care, who's at that highest risk. What we don't know yet is, can we make a difference, right? If we were doing a better job at evidence-based medication prescribing, could we lower that risk? We don't know. There are a lot of questions that are starting to emerge as we're looking at this data. Now, if we come back to the story of TAVR, this is not big data, this is small data. It's about 250 people who were seen locally in Boston at the Beth Israel Deaconess, right where the partner trial was being conducted. And it looked at, can we identify who is most likely to benefit from TAVR, not for mortality, which while that's important, it may not be what our patients care about the most, but actually for functional status outcomes. And so this is looking at months after the procedure based on baseline functional status, which is also captured by their baseline frailty index. It turns out that those who had excellent or good, or even fair functional status before TAVR had a reasonable chance of a year later coming out with the same or even better functional status. This is not all that different from that first slide where I showed that somebody who's frail is more likely to, somebody who's fit is more likely to be able to get back to their functional baseline after some event. In this case, this is a planned scheduled TAVR. For those people who were not doing as well before the intervention, they never got back to their baseline. And that's a really important question when we talk to our patients. Why do they want to do the TAVR? Well, maybe their shortness of breath or their syncope is so bad that they just want to be able to sit there without symptoms. Or maybe they want to, walk their grandchild down the aisle. Those are very different things that we might want to think about in terms of functional outcomes. And coming back to the question of age, turns out that frailty is relevant even in younger people undergoing cardiac surgery. So this is data we just published also out of the VA, also using that same electronic frailty index. And what this shows is overall, these are patients who are selected for CABG. These are elective procedures across the nation, about 17,000 people who had undergone CABG in the last decade. And what we found was that taking a step back, I was working with a surgeon who, Salil Deo, who's one of the leads of this paper. And what he was saying is, we do a really good job of knowing who's really frail at very old ages, right? So people aren't getting CABG if they're very frail, if they're in their 80s. And we saw that in the data, right? Frailty didn't actually make a difference in terms of outcomes for CABG. Where it made a difference was in people in their 60s, 70s, and especially in people who were less than 60, all the way down to about people in their 40s. This is first data of its kind to really say, don't look at that chronologic age, really think about what is that underlying biologic age for your patient. Well, what about evidence-based medicine? What about clinical trials? So many older adults that we care for have been excluded from clinical trials. They don't meet the criteria. For many years, that was because there was an age cutoff. And then it was, well, people are getting around it now. They're saying life expectancy cutoff. Don't include people if they have less than 2 years of life expectancy estimated. Don't include them if they're nursing home patients, if they have dementia, if they have comorbidities. And yet we need to know whether the medications that we think will work to help lower their risk of cardiovascular endpoints, and so on, actually make a difference. So when we think about frailty in the context of a clinical trial, we think about generalizability. We think about frailty as a modifier of our endpoints, and even potentially frailty as an outcome. Some of the things we do to prevent cardiovascular disease also prevent frailty. So there's a ton of data out there. I just picked a handful of studies which are really, really interesting. So going back a decade to the RELY trial, this is dabigatran versus warfarin, just as the NOACs were first coming out. Very strong data and very strong evidence to show that there is a reduction of stroke risk and a reduction in major bleeding. How does that hold up in the population? Well, it turns out if you look at the blue lines over here, really, really similar. So this is Medicare data. This is not trial data. This is replicating a trial in Medicare. And the overall results were basically the same, which is very good to see. And same, no increased risk of major bleeding. When stratified by frailty, those who were pre-frail, maybe there was a benefit, but actually if we're looking at this properly, there's no interaction for frailty. There was no difference for dabigatran. But then the real question comes, well, is there a difference between all of the different NOACs that we have now, dabigatran, rivaroxaban, apixaban, doxaban? Does it make a difference for people who are frail? And it turns out that for people who are non-frail, this is looking at dabigatran, rivaroxaban, and apixaban, also in Medicare data, you can replicate each of the trials. In the non-frail, you get the same hazard ratios or very similar. And yet for frail individuals, only apixaban seems to show a benefit for reduction of, this is actually a composite of looking at stroke, bleeding, and death, but even when you parse it out. What's most remarkable amongst the frail, if you look at these curves down here, the absolute reduction in events is 4-fold higher in the people who are frail. They have the highest rate of events, and you're getting the greatest reduction in events. This is actually pushing Medicare in the US to make apixaban the drug of choice for atrial fibrillation. So we're going to be seeing that coming from the FDA and from Medicare quite soon. The other question is, well, what about some of the novel agents that we're using now in heart failure, the ARNIs, the SGLT2 inhibitors? What about frailty in that context? So this is some really fascinating data just published in the last year. First, looking at the Paragon HF trial. This was a post hoc analysis. So this, we all know how Paragon HF ended. It had a hazard ratio of 1.01 on the upper limit, and it was the New England Journal considered that a non-significant trial, even with a hazard ratio of 0.745. Clinically, probably very meaningful. And when you start to look into the subgroups, it turns out that people who are frail had the greatest benefit, which is actually, I was shocked when I saw this data. And many of the geriatricians were saying, well, we want to deprescribe. We don't want to start prescribing more medications. But then the question becomes, well, what if there are some medications that are actually going to be really beneficial? And some of the real world data, I didn't bring it now, is extremely exciting to see the reduction, not necessarily in mortality, but in hospitalizations. And if we think about trajectories for people who are frail, being able to prevent that hospitalization cycle and keeping people out of the hospital is probably the most important for their functional outcomes. So this is Paragon HF. Now looking in the HFrEF space, this is SGLT2, dapagliflozin versus placebo. There was actually no difference across all frailty levels. Everybody benefited. This was also a post hoc analysis. Very interesting. Now DELIVER, which is a very new trial, as I think most people here know, is just starting to change the heart failure guidelines to make the SGLT2 inhibitors a class 2A recommendation now in HFpEF. Well, although this is not a statistically significant difference, there is certainly a trend towards greater benefit amongst people who are frail. We're not seeing greater harm. And to me, that's the most important. Now, of course, the big question, what about side effects? What about all of the other adverse events that can happen? We do, of course, need to keep in mind the urinary tract infections and the SGLT2 inhibitors, absolutely. All of the potential hypotension, syncope, electrolyte abnormalities. But across the board, turns out that there was no difference if you were frail or not frail. If you have heart failure, you are at risk of all of these bad outcomes happening. So you got to be careful. If you're frail, at least in this data, in these trials, there's no difference. I want to point out that in DELIVER, it was a pre-specified analysis of the trial, which is the first time that we're really starting to see that. which is incredibly exciting as we think of developing the evidence base for these for the medications that we're going to use for our patients. So I want to know, I was just rounding in the nursing home on Sunday and seeing a patient with an acute heart failure exacerbation who probably really needs an ARNI. Well, I'm going to go for it because we've got this data that suggests that she needs it. What about frailty as an outcome? Well, there's not a lot of data. This is the look ahead study. This was a lifestyle intervention in people with diabetes. What was actually very interesting here was that there was a reduction in the frailty index in the people who received that lifestyle intervention, the intensive lifestyle intervention. We're talking diet, exercise, compared to people who just got the education. What was not seen here was a difference by the Fried phenotype, that physical phenotype. There's probably a ceiling and floor effect of the Fried, whereas you can make a difference on a lot more different points for the frailty index. So this is a whole new way of thinking about frailty. Can we actually make a difference to lower somebody's frailty? And then downstream, we don't know yet, presumably lower their cardiovascular event risk. All right, that's been a ton of data. I know this is cardiology grand rounds, that's how we like it. Now, how do we actually measure frailty? What do we do in clinic, right? You're not going to do a 90-item screen. So how can we do it? So I like to think about this as, where am I? How much time do I have? What can I actually do with the patient in front of me? So there are some rapid tools that take less than a minute or maybe no more than 2 minutes. There are some what I call medium length tools. And then there's what do I do when I'm wearing my geriatrician hat and I'm seeing somebody in the geriatric. So this is, I'm sorry it came out so small, make sure to share my slides. This is what's called a rapid geriatric assessment. But what I really want to highlight here are not these specific tools, but actually the Frail questionnaire. This has become a very powerful tool to use. Actually, in some clinical trials, we're using this to screen people in. It's very, very similar to the Fried. You'll note it has 5 components, but what it has that the Fried doesn't have is a measure of how many chronic conditions do you have? Do you have 5 or more? And in some ways, this is a melding of the Rockwood and the Fried, which is really nice to see. It has the same ceiling and floor effects, but it's a really wonderful tool. We actually use it in all of our orthopedic outpatient clinics as a quick screen to say, hey, let's bring you in for additional screening before some joint replacement. Grip strength is a fantastic measure of choice for assessing overall strength. If you work with occupational therapists, they can do this for you. I have had a dynamometer in my trunk for over a decade. I have not taken it out since fellowship. So what can I say? I'm just going to be completely honest. It's hard to use because you need to calibrate the dynamometer. You need to know the different cutoffs for men and for women by BMI. And yet it's a really powerful tool. We use it mostly in research. So my research assistants use this. And again, our occupational therapy colleagues will use it. The 30-second chair stand is an excellent tool. This is being encouraged by various different guidelines. It's just seeing how quickly can somebody, or how many chair stands can somebody do in 30 seconds. We've been sitting here for a long time. I'm going to move away from the mic for a second. I want everybody to do a chair stand with me. All right, we're all on the wheeled chairs, which is not ideal, but the way. Without using their arms. And then you can prescribe that, right? If somebody can't do 2 or 3, prescribe, do 2 or 3, not right after breakfast when you have hypotension, but sometime mid-morning, and try to build up to doing 10 of those. That's the quad muscle. That's the most important muscle for balance. It's the most important muscle for being able to transfer and for being able to walk. Most people think it's core. It's actually the quadriceps in the older adult. You can combine the chair stand with a walking test. This is a really nice tool to see how can somebody manipulate their home environment. How are they managing just from getting from the chair to the washroom and back, or to the kitchen. And it turns out that the timed up and go corresponds really well to the Fried. So you can do that quick assessment that only takes 20 or 30 seconds. And you don't have to spend all your time doing those 5 different assessments for the Fried. So somebody who has a timed up and go that's less than 10 seconds, not frail. And that's really useful. My favorite tool and what we've been incorporating in our cardiology clinics for the last 7 or 8 years is gait speed. And that's because it's a phenomenal integrator of health across all body systems. I always tell my students, which body system is not involved in walking? It's a trick question. Every body system is. And, you might say, what about the gut? Well, if you've got B12 deficiency, how are you walking? Right? We could think through that later if anybody's interested. So many people in the physical therapy literature have advocated for walking speed as a 6th vital sign, and shown here, this is a nomogram of what is normal walking speed over life course. So if you're in middle age or younger, most people are walking pretty quickly. If you've been to the Northeast and you come out to Boston or New York City, people are zooming along. And the traffic lights actually kind of go with their very fast walking, which is not great if you're an older adult, because an average 80-year-old is going to be walking 1 meter per second. But those traffic lights are actually set at 1.2 meters per second. So that's an environmental thing we have to think about. A seminal paper in 2011 in JAMA, done by Stephanie Studensky and colleagues from Hopkins, pulled together data from 9 different trials of 30,000 individuals who had 4 meter or 5 meter gait speed done. And they were able to show really beautifully that a slower gait speed is associated with lower median survival. And the cutoff of about 0.8 for the general population is what's recommended. So if you can walk 4 meters in about 5 seconds, you're fine. If it takes you more than 5 seconds, so less than 0.8 meters per second, then you're in trouble. Or at least we should think about how can we help your walking do a little bit better. And it also turns out that improvements in walking speed by 0.1 meter per second can actually decrease 1-year mortality by 10%. Not a lot of drugs can do that. And so this comes back to, if exercise was a pill, we would all be taking it, right? What's really neat about this statistic, just to have this, take this one home with you, is you could speed up somebody's walking by giving them a walker, by replacing their knee, doing a TAVR. Doesn't matter what it is that you're doing to improve their walking, you're going to lower their mortality risk. So we actually, like I said, this is data over 5 years in our VA Boston cardiology clinic. We found that it wasn't so easy initially to get this started. This is a run chart just showing how we were able to implement gait speed. Once we got it into the record as a vital sign and part of our physical exam, it was quite easy to do. We actually found that our fellows were the ones who were doing the assessment. You can see this is our hallway here. And just from where this tile color changes, I don't know if you're seeing the mouse here, where the tile color changes here from white to green until this second room here, number 8, was exactly 4 meters. It made it so easy because every patient had to walk down that hall. That second room is the attending room. So, the attending could poke out and say, hey, you're doing the walking speed. We had a fellowship class that didn't like it. There was no buy-in. What can I say? But actually, I have to say, since COVID, these numbers have sustained. Almost about 90% of patients who are ambulatory and come into our cardiology clinics are getting a gait speed assessment, and we're using it for anything. The most dramatic case we had was an individual who was wheeled in by his wife, and she said, oh, he's just not walking anymore. I don't have a good reason why. And I said, well, let's just see how you're doing. And he gets up, and of course, Levine sign, right? So he said he's not. Our clinic to lab time was about 29 minutes that day. It's fantastic. He was having a STEMI, and he had just literally stopped walking because he was having chest pain. So we have been able to turn all of these recommendations for mobility assessments into this wonderful video. This is Kristen James, who was my fellow a couple of years ago. It's actually her dad is the actor. Here, just showing how to do these chair stands and walking speed and other balance tests that you can do. Very low tech. You don't need anything fancy. If you don't have a stopwatch, you can just use a second hand on your watch. If it's more than 5 seconds, that's already given you a tremendous amount of information. So feel free to go through this. It's got a lot of practical tips. What was really fascinating is that we had clinicians reflect on their experience of using this, because it's one thing to say you should measure frailty. It's another thing to actually do it. And we had one attending who said, this has given me such a simple tool. I'm monitoring my own gait speed, which was really cool. I had a nurse practitioner who said, I never realized how many patients were frail. And then conversely, I had a fellow who said, not everyone's as frail as I thought, right? So that had a bed test, right? We could do better. Briefly going to mention cognitive frailty. It's a good idea to think about screening using a brief tool. The intention of today is not to make everybody geriatricians, but just to make sure you've heard some of these tools. The mini cog again is a really, really great one. All right, as we're starting to wrap up all the different tools we can use in the clinic, the Clinical Frailty Scale, another homegrown Canadian tool out of Dalhousie from Ken Rockwood, is a brilliant rapid assessment of frailty that I recommend everybody use. You can use it in ER. We use this for COVID for triage. You can use it in the ICU. What it really does is it requires a little bit of questions from the patient or family of how are you managing in the last 2 weeks? And the questions are really focused on how were you managing in terms of your own life space? Were you managing your bills and pills, or did you need some help? Were your, symptoms getting in the way or not? And based on this, you can figure out, is your patient living with mild frailty? Are they very severely frail? Somebody who is bedbound in a nursing home is going to be very severely frail. It gives us a common language that we can use based on someone's functional status. And this clinical frailty scale corresponds very closely with single markers of frailty, whether we're using the gait speed, grip strength, or others, which is great because you can't necessarily walk somebody if you're seeing them on the floor, but you can do a clinical frailty scale. And the CFS was also was able to identify those who were at the highest risk of mortality in the Ocean Tabby and Frailty ABR studies. So the clinical frailty scale has now been included in the ACC NCDR, or the National Cardiovascular Disease Registry. I know several hospitals in Ontario are involved. I don't know how far across Canada the different hospital systems are that have gotten involved, but this is allowing us to now look at frailty in the context of real world patients, right? Because we can't always get EHR, but we do have these registries, and what's been missing is their frailty. The Essential Frailty Toolset is specific to TAVR, also from John Filalo and his group in McGill. This one brings together some of the things we've been talking about. So the ability to do those chair rises. Does your patient have cognitive impairment or not? What is their hemoglobin? What is their albumin? Markers of inflammation, markers of nutrition. And if they only have one, well, their risk of 1-year mortality after TAVR or SAVR is no different than it would be just based on the procedure. If their risk is higher, then it's something to consider. What's really interesting is this brief tool that brings together multiple different domains that we've been talking about. Does just as well or better than almost every other one of these different tools we talked about, the Freed, the Rockwood, and Edmonton, and other things as well. It is readily available as an app online. It's called the Frailty Tool. Nobody gets any money for this. Nobody's paid for this, but it is a phenomenal tool that Dr. Filalo has made readily available that you can use in your clinic. It'll pull up that mini cog so you don't have to remember it. It'll pull up gait speed and so on. Now, finally, if I was wearing my geriatrician hat and seeing somebody in Geriatrics clinic, this is the tool that we use in Boston in many of our systems. It's actually embedded in one of our healthcare systems at the Beth Israel Deaconess Medical Center. And it's that comprehensive geriatric assessment Frailty Index. It requires at least a dozen different medical history components, about 20-25 different functional assessments. And then if performance status is available, that's fine. The point here is just to show you what it might look like if you wanted to use this tool. It gives you domains that you might be able to use then to develop a differential diagnosis and treatment plan. So this is why we find it so useful. This patient who I plugged in, their major domain is cognition. We can't usually change that, but there's also muscle strength and mobility. So those are things that are intervenable. So if this represented a patient I was seeing before surgery, well, I might want to be thinking about their delirium risk, but can't do too much about that, but I certainly can do some prehab and think about muscle strength. So with all of this, bringing it back together to our two patients. So we've got our retired engineer who's younger, but maybe having some trouble around his cognition. And then we've got our retired pharmacist, 86 years old, needing a little bit more help functionally. One is thinking about anticoagulation, one is thinking about TAVR or SAVR. So for Mr. D, we did some cognitive testing. We did a frail scale. He actually was pre-frail on the frail. The clinical frailty scale put him at about mild frailty. His gait speed was just under that pointing, just a little bit slow. And again, he failed that cognitive test. Importantly, though, his CHA2DS2-VASc score is high. So this is somebody that we want to anticoagulate, right? So the way we put them together was, this is somebody who's mildly frail. Now you'll note that not all these different tools line up exactly. That's okay. Overall, this is somebody who really was giving a picture of mild frailty. His cognition is something we really have to think about. Is he going to be able to manage taking his pills? We know there's a black box warning on all the NOACs. If you start missing pills, you actually are at a higher risk of stroke because of that acute pro-inflammatory state. So we really need to engage his family, but our recommendation was a Pixaban for stroke prevention. Then there's Mrs. Y. So we did her comprehensive geriatric assessment frailty index. This is, of course, preoperative planning. So we spent a lot more time with her. And she showed up as moderately frail, driven really in large part by many of her comorbidities. At the same time, her CFS was only 5, so also mildly frail, a little bit less than we might have thought. Her gait speed was slow. Without a walker, it's 0.6. It's sped up almost 0.1 meter per second just by giving her a walker because she was so unsteady. Her EFT, though, that essential frailty tool set, was only 1. So when we're being specific in terms of TAVR or SAVR, her biggest limitation was actually her functional status. So her risk in terms of the procedure itself is lower than we might have thought. She's still somebody who maybe there are things we could do around prehab or to help mitigate that functional decline post-TAVR. But she's somebody who would probably do quite well. And she did. She did. We actually enrolled her in a 4-week exercise program. Her walking speed came up just a little bit, but more important than that, her muscle strength was better and she was feeling a little better going into surgery. So as we bring this all together, which frailty tool is best? The answer is the one that you use. And the reason I've been putting so many different tools out here is to just give you a sense that they all work. And it really doesn't matter which one, just as long as you can use one of them. I want to point out that frailty is dynamic. It's a disease state, but it's not a reason to withhold care. So for Mrs. Y, she actually did really well after her TAVR, and she was able to do so much more. Her functional status really improved. And she's still living well, still in assisted living because of her comorbidities, but doing well. Frailty is an opportunity to personalize care plans and to minimize risk, especially when we're talking about elective procedures or adding medications. And I like to call this precision gerontology. Era of genetics, sometimes it's really the low-hanging fruit that can make a difference. I want to point out the risk of left digit bias in clinical decision-making. For our 79-year-old, I don't know how many people really would have started to think about frailty for him. For our 86-year-old, kind of like, whoa, stop, put on all the brakes. We got to make sure that she's ready to go for TAVR. And there's some really interesting literature that this paper, brilliant paper, unfortunately was published just as the pandemic started. So I think it hasn't gotten a lot of attention, but this looked at the difference between frequency of CABG performed in the 2 weeks before the 80th birthday. So 79 and 50 weeks old compared to 80 and 2 weeks old. There is a significant difference in the number of procedures performed. This is using Medicare data. And 30-day mortality outcomes are significantly different. Now that difference, yes, overall amongst people who are in their 70s or 80s, there's an overall difference in people who are offered CABG or not, but there cannot be anything other than left digit bias going on over here, right? Just because somebody in their chart says they're 79 or they just turned 80 is not a reason for us to be seeing this kind of difference in the data, both for offering a procedure and then for outcomes afterwards. So something to be mindful of. And finally, going to end on this note, is frailism the new ageism? We want to be mindful, especially as more tools become available to us to, in an automated passive way, identify who's frail in an electronic health record, that we're not just applying a label and then walking away and not doing anything, because there are things that we can do. I want to say thank you. It's been a real pleasure to be able to be here. I'm excited to talk with folks today. Also, just want to say thank you to those who have been helping care for my own grandfather who lives here in Calgary and has his own cardiac conditions. And this was a couple years ago when I brought my son to visit the Calgary Zoo before COVID. So thank you. A really good question. So to answer the first question about ICDs and frailty, there is some data, there's not much. I was involved in the systematic review a few years ago where we looked at trying to answer that question. It kind of goes both ways. On the one hand, people who are frail are less likely to get an ICD. On the other hand, when they do, it seems like they have higher risk of complications. Even simple things, a battery change should not be anything more than a same-day procedure. And yet it's somebody who's frail who's more likely to run into trouble with infections and so forth. It is an active area, so definitely something to keep in mind. What I will say as far as ICDs particularly, you know, the question of time to benefit, the question of life expectancy is the biggest question that I know I've been consulted on that a number of times. Somebody with advanced frailty with an EF of 15%, what are their goals? Why would we put in an ICD in that person? Right. So it's an important question. We need more data, which is often the answer here. It's not satisfying, but there hopefully more to come on that. With regards to frailty in people over 90 or into 100, there's an interesting survival effect, right? If you've made it to 90 and you're not frail, you're much less likely to become frail. If you're in your 90s or 100s and you're frail, so the answer is the tools work. At a population level, we don't have a ton of data, but they do seem to work. When you're getting into questions of how effective is your measurement tool, if you're running into a question of language barrier or so forth, and maybe a functional assessment is better. Your point of what do you do with somebody in a wheelchair? Maybe that's where the grip strength really becomes most efficient or most effective. You know, call your colleagues in geriatrics and see if maybe they can't help. I hope I'm not creating more work for folks, but there, you know, sometimes a team approach is really what is needed to be able to help there. Yeah, so it sounds like a twofold question. One is how good is that passive or EHR based assessment compared to what we do in the clinic? And then the other is what do we do in the virtual era where we can't really get functional assessments? So the first question, you know, how well are they correlated? I shared the Canadian data, which is really good. We have very similar data from our own clinics. In people who are regular users of the system, which is the key, and you have enough data, then the scores work really well. Where it doesn't, or it breaks down and they're experiencing this in the UK and we're learning from them, is if you don't have the data, you can't measure a frailty index. So you do run into trouble. You know, if it's your primary care patient being admitted to the same hospital, you'll be fine. But if you have somebody coming in looking for a specialty care and you have no information, then you're in trouble. So it's good at a population health level. It's good as a screening tool for primary care patients. Beyond that, we still have more to do. As far as what to do in the virtual era, so you can do most of these assessments you can do virtually. In several of our clinics in Boston, we were virtual before the pandemic because we're a referral center for much of New England. And so we don't want, and it's specific to geriatrics, we don't need people driving 6 hours from northern Maine from the Canadian border to come down to Boston when we can do something over a televisit. And so we've gotten good at seeing chair stands, right? You can do chair stands virtually as long as somebody is there and they're not on a wheelie chair. Or we use other tools that don't require functional assessments. Yeah, that's a really good question. So the natural history of frailty, the best data we have is very outdated and doesn't reflect the current generations. But what is clear is that across the population, if you looked at the Frailty Index, and Ken Rockwood has shown this really nicely, you get about one deficit per year over the course of the population, right? So what that means is every year you get a little bit of incremental increases in the Frailty Index. There's a maximum, right? And people can't survive. And so it's not exactly homogeneous across the population. That said, there are certain things that will lead to a big increase in frailty. So if you've had a stroke, cancer diagnosis, accident, right, things like that. But there are trajectories. People recover and absolutely get better. There is also frailty of aging, which is just part of the aging process. And as we learn more about the biology, I actually have a slide here where this is about to come out in JACC Advances. We're looking at what is the interconnection between hallmarks of aging. So all the things that are underlying the aging process, right? Organs don't last forever, cells don't last forever. How does that drive what we call the geriatric 5 M's, all those different domains of health for geriatrics, whether it's your mobility, your mind, and so forth, and then how that ties in this case, we're talking about cardiovascular disease, but it's not a linear trajectory for sure. And there are things we can do to improve. If you're starting off in your 60s and 70s not frail, you're much more likely to remain not frail. Just like if you're starting off without diabetes in your 70s, you're much less likely to become a diabetic. How closely those are interconnected is actually a yeah, so women have a longer life expectancy than men. And so exactly right. We see higher rates of frailty in women than we see in men. And part of that is a survival effect. There may also be a hormonal difference. Postmenopausal, there might be a difference. There might be a protective effect of testosterone in men that we're not seeing in women. I know we're over time. But it hasn't all been disentangled. The other piece is that's also very interesting, especially when you look across global frailty markers, and you look at populations, in South America, which are very supportive of their elders. You get these high levels of frailty, but people are living at home, and especially women seem to actually have more support from their children than men, which is fascinating. The women are supporting their spouses, but the children are supporting their mothers, which is social networks. We don't have an answer. Some of it is biology, some of it is just survival bias, and that's what we're seeing in the data. And other things are obviously just the social. Great question, more to come. I'm excited to meet with folks. I don't know if there was any